In the past decade, physicians have become increasingly aware that a significant number of patients coming to their offices or clinics have a history of having had an acute depression from which they did not fully recover. It is now estimated that approximately 15% of the patients with depressive illness remain chronically ill or in partial remission following an acute depressive episode. These patients often are a diagnostic and a therapeutic challenge to the physicians they consult. Dr. Nelson Hendler and Dr. Frank J. Ade Jr. have met to discuss the problems posed by the chronically depressed patient. Dr. Hendler is Assistant Professor of Psychiatry and Assistant Professor of Neurosurgery in Psychiatry and Psychiatric Consultant to the Pain Center, Johns Hopkins University School of Medicine. Dr. Hendler is also Medical Director of Mensana Clinic, a private care facility outside Baltimore, Maryland. Dr. Ade is Professor of Psychiatry, West Virginia University Medical Center, Charleston, the Director of Professional Education and Research at Taylor Manor Hospital, Ellicott City, Maryland, and editor of the International Drug Therapy Newsletter. Now, to begin this dialogue, here is Dr. Hendler.
Thank you. Before talking about the diagnostic and therapeutic problems posed by the chronically depressed patients, I think it's imperative to discuss the epidemiological considerations of this problem. Dr. Norman Sartorius, the Director of the Division of Mental Health of the World Health Organization, has called depression the world's major public health problem. In fact, he estimates, based on the World Health Organization figures, that at any one time in the world there are approximately 100 million clinically recognizable and treatable depressed patients. If this is true, and it probably is, and there are 100 million clinically depressed patients at any one point in time, it's estimated that 15% of these patients go on to become chronically depressed. These 15 million chronically depressed patients are a prime reason why depression can be designated the world's major public health problem. However, despite the prevalence of chronic depression and the frequency with which these patients visit physicians, chronic depression often is not recognized or diagnosed. Frank, I was wondering what symptoms should a physician look for to enable him to make the differential diagnosis of chronic depression?
Well, Nelson, the victim of a chronic depression invariably is a woman, age 35 or older, who has a neurotic-type depression. Typically, she is a unipolar, not a bipolar depressive, who seldom becomes ill enough to require hospitalization. Usually, when she first becomes ill, she is reluctant to consider herself emotionally disturbed or in need of psychiatric treatment. Instead, she goes to her family doctor or favorite specialist thinking there is an organic cause for her symptoms. She willingly undergoes various diagnostic tests, and when these are negative, she goes to a psychiatrist, but only because she is advised to do so. Then, when diagnosed as depressed and treated with an antidepressant drug, she improves only partially. That is, the more acute characteristic symptoms of melancholia abate, but she continues to complain of fatigue, anergia, anxiety, and tension, and of a variety of somatic symptoms of mild to moderate intensity. Thereafter, usually after antidepressant drug therapy has been discontinued, her mood remains despondent, even though anxiety symptoms are predominant. Seldom does she now complain of anorexia or weight loss, or of the sleep disturbance characteristic of an acute endogenous depression. Rarely does she appear depressed or have crying spells. When she goes to a doctor, she emphasizes her somatic symptoms, her fatigue, tension, irritability, and so forth, and denies feeling depressed or grudgingly comments, "If you felt as badly as I do, you would be depressed."
Frank, that's exactly what we see at our clinic.
When these women come to the office, they are usually neatly dressed, seem anxious, and not depressed. They exhibit no evidence of a physical or mental slowdown. They are solicitous about what is or has been happening to them, and unquestionably they want treatment that will provide relief from their distressful symptoms.
Frank, I was wondering, do these women actually look depressed?
Not usually. On the contrary, they act anxious. But they do have mild symptoms that are characteristic of an endogenous depression. If they are carefully questioned, they hesitantly acknowledge that their mood is depressed, that they are not as energetic or as interested in their usual activities as normal for them, that morning is the worst time of the day, that their feelings are not influenced very much by the environment, and finally, like all truly depressed patients, they are pessimistic. They are self-depreciatory, and they tend to blame themselves for their illness and its impact on their families.
That's an important point. I think we'll come back to that later, but I want to stress the impact on the family.
I should point out that since these low-intensity manifestations of depression are overshadowed by the patient's anxiety, it is understandable why a diagnosis of anxiety is made, a tranquilizer is prescribed, and the depression is not recognized. Yet, if doctors would only realize that depression can masquerade as anxiety, they would think depression more often when a woman consults them and gives a history of being chronically ill, of reliance on minor tranquilizers, of being worrisome and unable to enjoy life, of moodiness, and of a lack of vitality. Finally, I think a doctor would be more apt to recognize and diagnose depression if he pays strict attention to the patient's attitudes toward her symptoms and not just to the patient's symptoms. Invariably, as you know, the patient's attitude is that symptoms are a sign that something terrible is happening to her. Such an attitude, in my judgment, reveals the pessimism of an underlying depression. As a psychiatrist, I have to say that many of the patients with the symptoms I have just described as indicative of chronic depression would not be diagnosed depressed by many psychiatrists. Instead, I think many psychiatrists would label these patients as having either depressive character or a chronic anxiety neurosis.
Well, many psychiatrists occasionally do not diagnose chronic depression. Instead, as you mentioned, these psychiatrists are inclined to categorize these patients as having either a chronic anxiety neurosis or a depressive character. This fact suggests that most psychiatrists have been trained to think anxiety and not depression when the patient complains primarily of anxiety, tension, fatigue, insomnia, guilt, and so forth, rather than of a psychomotor retardation or depressed mood. Now that we have drugs that are rather good anti-anxiety agents and drugs that are rather good antidepressants, it's essential that doctors be able to distinguish depression from anxiety. This is particularly true because there is ample data to substantiate that anti-anxiety drugs are of limited value in the long-term treatment of depression, whereas there's ample evidence to support the value of antidepressant therapy for acute and chronic depression. Furthermore, the long-term use of minor tranquilizers is not without some risk of either psychological or physiological dependence.
You've seen quite a number of depressed patients who had taken or were taking gradually escalating doses of an anti-anxiety drug in a futile effort to obtain relief from anxiety secondary to depression, and who, in fact, had developed quite a tolerance for the anxiolytic agent.
I couldn't agree with you more. I've also seen some of the minor tranquilizers in fact cause depression. A few of the patients have actually experienced withdrawal symptoms following abrupt discontinuation of the high dosage of the anti-anxiety drug, and I think rather than make a snap diagnosis of anxiety and immediately writing a prescription for an anti-anxiety drug, a physician should try to do a good differential diagnosis and prescribe an anti-anxiety drug only when this is clinically justified and only on a short-term basis. If physicians would do this, there would be less overuse of anti-anxiety drugs and less criticism of the extensive prescription of anti-anxiety agents. This would be advantageous for two reasons. Anti-anxiety agents would be reserved for the patient most likely to benefit from these drugs, and there would be less danger of efforts to restrict the prescription of anti-anxiety agents because of concerns regarding their abuse and overuse.
I think you would agree that most psychiatrists feel that the available anti-anxiety drugs are good drugs. It would be a pity if we didn't have them available because they have not been appropriately prescribed by a few individuals.
Frank, I can only tell you, in the outpatient department in which I work, I see a great many chronically depressed patients, and in my experience, because of their persistent and diverse physical complaints, such patients frequently have a variety of medications prescribed for them, and costly and even at times uncomfortable, painful diagnostic procedures done on them. When the results of these procedures are negative, and again I want to stress when they are negative, two things usually happen. First, the patient is not considered ill and is rejected by being called a hypochondriac, hysteric, or neurasthenic. Occasionally, the patient may even be called a malingerer. Secondly, the patient is rejected by being given a prescription for a major or minor tranquilizer, and most often a minor tranquilizer, one of the benzodiazepines. Would you comment on these observations?
Yes, I would, Nelson. Chronically depressed patients typically have multiple somatic symptoms which they are convinced have a physical cause. Hence, they have repeated, costly, and at times uncomfortable or painful diagnostic studies done. To substantiate this, let me tell you about some data I've collected on over 100 chronically depressed patients, which revealed the following facts. First, these 100 patients, believe it or not, were seen by over 500 different doctors before the correct psychiatric diagnosis was made. Among these 500 doctors were psychiatrists and representatives of every medical specialty. Second, these 100 chronically depressed patients had, besides routine hematological, blood chemistries, and urine analysis, at least 6 additional diagnostic studies, including chest X-rays, cardiograms, electroencephalograms, CAT scans, gastrointestinal series, and other radiological screens. Half of these patients had repeated cardiograms and X-ray studies. Third, in addition, prior to being correctly diagnosed, these 100 chronically depressed patients were labeled, as you pointed out, neurotic, some were called crocs, and so forth. Fourth, I'd also point out that these 100 chronically depressed patients not only self-medicated with numerous over-the-counter remedies, but they took an average of 12 different prescription drugs. Heading the list of all the drugs prescribed for them was, as you pointed out, a minor tranquilizer, most often one of the benzodiazepines.
All too often.
These minor tranquilizers, Nelson, were prescribed primarily by non-psychiatrist physicians. They were, in my judgment, of questionable benefit to these patients and, in some cases, I believe, could be considered harmful. Then finally, let me make one other point, and that is that several of these chronically depressed women had been treated with neuroleptics for their anxiety, and 4 of them had developed tardive dyskinesia. Hence, I should emphasize that neuroleptics, even in low doses, should not be prescribed for more than a few weeks for chronically depressed patients.
Why is that, Frank?
Well, I think there are very good reasons for that. First of all, depressed patients, I believe, may be more at risk for developing tardive dyskinesia than schizophrenics. And secondly, there is no really convincing data that neuroleptics provide substantial benefit for chronically depressed patients.
That's an interesting consideration. Now, one other thing I'd like to point out. The neurosurgeon with whom I work has adopted a policy of having all newly referred patients bring to his office on their first visit all the medications they've been taking since their illness began. As a result, he has found that many patients come in with bags containing a dozen or more drugs that have been prescribed by 2 or 3 or even more doctors in recent months. Many of these patients have chronic depression as far as I'm concerned.
Well, there's no doubt about it that in this age of multiple drug therapy and patients shopping from doctor to doctor, that doctors would be well advised asking a new patient to bring to the office for their first visit all the drugs that have been prescribed, at least since the onset of the present illness. If he does that, patients will come with a bag full of recently prescribed drugs, and in my judgment, this could be a diagnostic hint that the patient may in fact have a chronic depression. And I would really like to stress that because of their unrelenting subjective distress and their persistent physical symptoms, and really their continued efforts to seek treatment, chronically depressed patients frequently visit doctors' offices and clinics, and rarely, and I mean rarely, do they leave the doctor's office or a clinic without a prescription for at least one drug.
They demand it.
That's true. In fact, often they get prescriptions for several drugs each time they see a doctor. And I think this is because doctors tend, and I hate to say this, but it's the truth, doctors tend to prescribe for symptoms rather than their cause. Consequently, chronically depressed patients usually become members of what I call the Brown Paper Bag Club. Members of this club, Nelson, either voluntarily or on request, bring to the office or clinic a brown paper bag containing the many drugs that they have had prescribed for them by multiple doctors. Now, if you take the time to examine the contents of the brown paper bag, it reveals partially filled bottles of tranquilizers, sedatives, hypnotics, antispasmodics, analgesics, vitamins, tonics, stimulants, and occasionally even an antidepressant or 2. And if you ask the patient, most of them will say that these drugs were of no benefit or at best transiently helpful.
I can understand that because, number one, the compliance rate is only some 14%. And in addition, some patients just haphazardly take these drugs in combination without any recommendation from a physician.
Right, and rarely can chronically depressed patients remember all the drugs that have been prescribed for them, and hence they cannot give a satisfactory personal drug history. So, by having them bring their medicines to the office, a much more complete and informative personal drug history can be compiled. And as you know, this can be very helpful, not only diagnostically, but in deciding which drugs should not be prescribed and which may be the drug of choice for an individual patient.
That's 100% right, because there are so many idiosyncratic differences from patient to patient and drug to drug.
Absolutely. Then another important factor in diagnosing and treating chronic depression is the attitude of the patient's relatives toward his illness.
That's the point I wanted to mention before.
Yes, well, you see, I not only asked them to bring the medicines to the office, I asked them to bring the family to the office. Nelson, what do you do about the relatives of chronically depressed patients?
In our experience at the clinics, many chronically depressed patients have strained interpersonal relations as a result of their illness. Certain symptoms are likely to cause considerable conflict between a depressed person and his family. These are changes in sexual urges and behavior, irritability and hostility of the patient, the fear of being alone, the loss of interest and indecisiveness, the persistent and diverse somatic symptoms.
Nelson, let me interrupt because I think that we've had exactly the same experience, and I'd like to ask you, do you find that this sort of thing frequently leads to lively squabbles, charges and countercharges, and threats of separation or divorce and so forth?
By all means. As a matter of fact, the longer a patient is depressed, the more doctor bills accumulate, the more laboratory bills accumulate, and drug bills, and you wind up with more trips to a doctor's office, clinics, and so forth, without any sign of significant improvement. After a while, the relative is bound to become hostile towards the depressed patient, and even towards the medical profession. And relatives almost always need help if they're not to be a hindrance to the patient's recovery. We see this with chronic pain patients quite a bit. Most families are perplexed by the patient's changed behavior. Usually they try to account logically for what's wrong with the patient, but their assumptions are seldom right. Some will agree with the patient's version of the causes of his illness. Others may reject it.
I agree about this because I saw that just last night, in which the son and daughter completely rejected the mother's explanation for why she felt as badly as she said she felt. So having the relatives there gave me some insights as to the frictions that were going on that I felt had to be rectified in order to help the woman, not just with drug therapy, but for her total care for her depression.
I think that's an excellent point, Frank, because very often the presence of relatives changes the diagnosis, and the relatives are a bit more objective, but they're also very subjective in their assessment of the patient.
In fact, relatives frequently forget the kind of person the patient was when the patient was well, and now they can accuse the patient of being lazy, a malingerer, or of lacking in willpower, so that they tend to be hostile and derogatory. And you know as well as I that these kinds of attitudes are certainly not conducive to expediting recovery for the patient.
Well, this is understandable. Now, I don't want to be judgmental about the patient's relatives, but this is understandable in light of the fact that they don't understand the disease. And this is one of the roles of a physician. If he can become the doctor in the true sense of the Greek word, he can be the teacher about the disease. And I think it's important that doctors give a relative of a patient a comprehensive explanation of the patient's illness and of the treatment that the physician has chosen, and also enlist the assistance and cooperation of the family. This goes a long way towards supporting a depressed patient.
I agree. In fact, I have found in my private practice that properly instructed, relatives can do much to assist the ill patient between visits to my office. They can do this by clarifying what I've told the patient, by reassuring the patient, and by protecting the patient. And this is very important, by protecting the patient from well-meaning but often ill-advised friends, and finally by making necessary environmental changes, and generally by fortifying between visits to my office the patient's desire to get well.
I think, Frank, if the patient is reacting adversely to the attitudes of a relative, it's imperative that the relative be brought into therapy with the patient, because so often they can undermine therapy if they're not properly instructed. And I think there's another component that we haven't mentioned, which is the anxiety of the family regarding the disease. And one way to allay this anxiety is establishing and having frequent contacts with the patient and the family during the treatment for chronic depression. Both the patient and the family profit from the chance to have misconceptions about chronic depression rectified, to have their anxieties allayed, and to have support and guidance from the physicians. This is imperative. In my experience, I say the involvement of the family is probably most beneficial for the patient. Some physicians, unfortunately, have a false economy. They're running a very busy practice and they feel that they don't have time to talk to the family of a patient. In effect, this creates more problems than it solves, and if they would just take the time to talk to the family, they would reduce the number of phone calls and anxious, frantic visits to the physician's office because they would become fully informed about the disease process.
Well, they would also avoid passive resistance. You know, time is very precious, particularly when one is in a busy practice. But it really only takes a few minutes to express personal interest in the patient and in the relative. The dividends in time and telephone calls ultimately saved by informed relatives are incalculable. The cooperating relative, as you would agree, I'm sure, is a real help in speeding a patient's recovery. Indeed, I'm sure you've had the experience I've had, that many depressed people report later on that if it had not been for the understanding help of the family, they could not have tolerated their illness.
Yes, I think it's a very frequently stated adjunct to therapy. One other thing I think we should talk about is the need for chronic long-term therapy. And I have two questions for you, Frank. Is long-term antidepressant drug therapy safe, and is it effective?
Well, Nelson, I should point out that in the past decade, an increasing number of studies have been done in Europe and in this country to determine the efficacy and safety of long-term tricyclic antidepressant drug therapy. These studies have provided data substantiating that such long-term tricyclic antidepressant drug therapy is efficacious and reasonably safe. Hence, an increasing number of patients, in my experience, are being treated with indefinite tricyclic antidepressant drug therapy, just as there are patients on maintenance neuroleptic therapy.
You're talking years now, Frank?
Oh, yes, and I think it might be good if I were to review here some of the studies that have stimulated this maintenance tricyclic antidepressant therapy. In 1973, for example, psychiatrists at the Maudsley Hospital in England conducted a double-blind clinical trial at 8 centers in different parts of Great Britain to determine whether patients making a good recovery from depressive illness with tricyclic antidepressants would derive any benefit from continuation of therapy with the same drug at a lower dose level. They found that maintenance tricyclic therapy was indeed efficacious and not productive of any serious side effects. In 1971, I reported on the results of a clinical and laboratory survey of 40 chronically depressed patients treated with doxepin from 18 to 41 months to maintain the symptomatic improvement this drug had produced. During this study, these patients took from 33,750 milligrams up to 253,000 milligrams of doxepin. When I compared their pre-treatment and survey urine analysis, hematological, renal, and liver function studies, I did not find any statistically significant changes. Doxepin was well tolerated by these patients, and particularly by those with cardiovascular and other disorders that they had besides their melancholia. I should also point out, Nelson, that there were no adverse interactions between doxepin, hypnotics, neuroleptics, antihypertensive drugs, oral hypoglycemic agents, anticonvulsants, and so forth. Side effects, none of which were serious, occurred with initial high dosage, but all, except slight dryness of the mouth and a tendency toward constipation, disappeared with the establishment of the maintenance dose. Hence, I concluded in 1971 that long-term doxepin therapy can be effective and safe for those chronic depressives who require indefinite antidepressant treatment.
That's a good point, because very often physicians will overlook the possibility of drug interactions.
Right, and yet I should also point out that we've talked about the number of drugs chronically depressed people take, and I think it's important to know that you can't stop them from taking these different drugs, principally because many of them do need them for coexisting physical illnesses that they have besides their chronic depression. And therefore, the question of whether or not there's going to be an adverse interaction between a prescription drug that they must take for another illness and the antidepressant that they must take for their chronic depression is an important issue.
Frank, I was wondering if you might be able to give me a rough idea of the dosage for this chronically administered doxepin.
Well, for most patients, this would be anywhere from, say, 75 milligrams a day to 150 to 200 milligrams a day. It is an individual thing. The important thing is to give enough to maintain the patient as symptom-free as possible and at the same time side effect-free, because we never encounter any serious side effects in this group of patients, although when we first started and were giving high initial doses, like more than 200 milligrams a day, then we did see some of the usual effects of doxepin. But all of them, except some slight dryness of the mouth and a tendency toward constipation, disappeared with the establishment of the maintenance dose. So I think a doctor has to realize that some patients will need a range of 75 to 150 and maybe occasionally 200, and in a very rare patient, even more than that. I want to stress that on the basis of all this data from these patients, I concluded that long-term doxepin therapy can be effective and it can be safe. And it's a good therapy for those chronic depressives who require indefinite antidepressant treatment. Later on, Clareman and his colleagues up in Massachusetts reported the results of a large study designed to assess maintenance treatment to prevent relapse and to preserve social performance in 150 depressed female outpatients who were treated with amitriptyline or with individual psychotherapy or a combination of the two. They concluded, and I quote, "The data from this study, taken in concert with a number of other studies, indicate the feasibility, efficacy, and safety of maintenance therapy with tricyclic antidepressant drugs." And we're both from Baltimore, and our colleague Covey over at Hopkins and his associates also have reported on the value and safety of prolonged antidepressant drug therapy. They stressed that their data verifies the general superiority of tricyclic antidepressants for maintenance therapy of chronic depression. I'd like to make another point, and that is that the majority of the patients in the reported studies I have mentioned thus far have been treated for less than 2 years. Hence, in 1975, I reported on data gathered from treating 40 patients with chronic depression or with frequent recurrent depressive episodes with doxepin for 4 years and 4 months to 7 years and 9 months. So we have a rather long period of observation of these patients.
Frank, during this period of time, what was the total dosage these patients received?
Well, we calculated that, Nelson, and it ranged from 200,000 to over 500,000 milligrams, which I think you would agree is a pretty good amount of the drug. And what we wanted to know was, did this protracted administration of this amount of doxepin have any adverse effects that we could pick up by laboratory evaluation, by repeated physical examinations, and so forth? And the answer was no.
I'm glad you said that, Frank, because probably, of all the tricyclic antidepressants, we're finding that doxepin has the fewest cardiovascular side effects.
Well, that certainly seems to be the opinion of many of our fellow therapists today. And as long as we're talking about, the problems of side effects and so forth, I should reemphasize again that in this review, we again found no adverse interactions between doxepin and a whole host of other drugs such as neuroleptics, antihypertensives, the hypoglycemics, anticonvulsants, and so forth. Consequently, I concluded that long-term maintenance doxepin therapy can be effective and safe for those chronic depressives who require prolonged antidepressant treatment, providing, and I really want to stress this, the therapist is willing to adjust dosage consonant with the fluctuating needs of the patient because they all don't require the same maintenance dose. What we found was that as the patient was on the medicine longer and longer, we could reduce the dose more.
This was due to the accumulation of blood levels, or of...
No, I don't think so. I think it's just that they've been stable for long periods of time, and it doesn't seem at least to be related to any saturation of tissues or of a particular type of plasma level, which we haven't been able to measure and didn't measure in these patients. But regardless, we did find that clinically some patients could be maintained on as little as 50 milligrams, others 75, others 100, and that maintenance dose, just like acute treatment dosage, had to be individualized.
So you basically titrate your response.
That's right. Now, the chief value of such therapy, besides its efficacy, I should point out, lies in the small degree of functional disability it causes. Maintenance doxepin therapy does permit ambulatory treatment for many patients over a prolonged period of time, and generally this is quite safe. The patients in this particular study on doxepin therapy can be called witnesses to what can be accomplished with chemotherapy by physicians who are willing to persist, to take legitimate risk, and to be innovative.
Unfortunately, it looks like our time is about up, and I was wondering if you had any concluding comments to make, Frank.
Yes, I do, Nelson. You know, many physicians don't know what it means to be the victim of a chronic depression, and hence they have reservations about the need for long-term treatment of this affective disorder. For those physicians, let me quote our British colleague John Scott Price, whose description of the existential position of the severely depressed was published in the May 6, 1978 issue of the British Medical Journal. And I quote, "Firstly, it is very unpleasant. Depressive illness is probably more unpleasant than any disease except rabies. There is constant mental pain and often psychogenic physical pain too. If one tries to get such a patient to titrate other pains against the pain of his depression, one tends to end up with a description that would raise eyebrows even in a medieval torture chamber. Naturally, many of these patients commit suicide. They may not hope to get to heaven, but they know they are leaving hell. Secondly, the patient is isolated from family and friends because the depression itself reduces his affection for others, and he may well have ideas that he is unworthy of their love or even that his friendship may harm them. Thirdly, he is rejected by others because they cannot stand the sight of his suffering. There is a limit to sympathy. Even psychiatrists have protective mechanisms for dealing with such cases. The consultant may refer the patient to a registrar's follow-up clinic. He may allow too brief a consultation to elicit the extent of the patient's suffering. He may, on the grounds that the depression has not responded to treatment, alter his diagnosis to one of personality disorder, comforting because of the strange but widespread belief that patients with personality disorders do not suffer. Fourthly and finally, the patient tends to do a great cover-up. Because of his outward depression, he is socially unacceptable, and because of his inward depression, he feels even more socially unacceptable than he really is. He does not, therefore, tell others how bad he feels. Most depressives, even severe ones, can cope with routine work. Initiative and leadership are what they lack. Nevertheless, many of them can continue working, functioning at a fairly low level, and their deficiencies are often covered up by colleagues. Provided some minimal degree of social and vocational functioning is present, the world leaves the depressive alone, and he battles on for the sake of his God or his children, or for some reason which makes his personal torment preferable to death." End quote.
That's some quote.
That is quite a quote. So surely, Nelson, all doctors must acknowledge that depression is a painful illness. It is a cause of so much suffering that any surcease we can provide is certainly welcomed by the patient and should be a source of immense satisfaction to the doctor.
You have just heard Dr. Frank J. A. Jr. and Dr. Nelson Hendler, participants in Studies in Psychiatry number 10, an audio cassette series presented to psychiatrists by Pfizer Laboratories. For full prescribing information, please refer to the sine qua non product information included with this tape. Thank you, gentlemen, for participating in program number 10 of the Studies in Psychiatry series.